Good afternoon. I'd like to welcome everyone to our second webinar, joint sponsorship with the MISH International Implant Institute and 3D Diagnostics. I'd like to welcome everyone back and thank you for all the great comments we had from our first webinar. As you can see, this is a little bit different, a little bit of an interactive webinar, and it's worked really, really nice. So we have a lot to go over tonight, so I'd like to get started. And for some of the attendees who weren't on the first webinar, the treatment planning component of the MISH Institute on Saturday morning, what we do is we have our attendees submit cases to us. 3DDX reformats them, and then we treatment plan them as a group. And it's one of the most popular parts of our continuum. And so we thought it'd be a great idea to do it in webinar form, which has worked out really, really well. So again, this is our second one. So with that being said, I'd like to tell you what we're going to do today. We're going to go over two cases. These are MISH attendee cases that doctors have sent these cases in. We've evaluated, reformatted them, and treatment planned them. And we're going to go through the start to finish from the medical history to the final treatment plan. And I'm going to ask questions during the process from the start to the finish. If we first look at how this will work, we will first start with the patient summary. I will go over the medical and the dental history, any medications the patient's on. I'll explain the chief complaint the patient has, and then I'll explain what the doctor's concern is with this particular case. That will be followed up with a complications part where I will discuss different aspects of the case which would be very difficult, or where I can see some people getting into complications. And again, as I said, we will ask questions with those said complications. Then we'll go in and actually do interactive treatment planning, where we'll plan out the sites and put implants in, look at vital structures, and come up with a treatment plan. These questions, I will actually read the questions, read all the answers, and then you will be able to, this is what will pop up on your screen, the actual question, and then all that you will do is you will mark which answer you think is correct. Now what we will do about 15 seconds after we put that up, we will put the polling up, and you'll see what the other attendees have answered. And again, I will explain all the answers, correct and incorrect. If during the webinar you have any questions concerning anything that I have said, any questions about the scans, any questions about the medical history, you can submit those by going down to the bottom of your screen and hitting the Q&A and submit the questions. At the end of each one of these cases, I will answer a few of the questions. Then at the very end of the webinar, usually in about an hour, we will go over the majority of the questions. If some of the questions we don't get to, we will also answer those via email. Today, you will be receiving most likely 2 hours. The last one went almost 2 hours of CE from the MISH Institute. Heidi, who's our administrative director, will send this out usually via email within 24 hours. So look for that sometime tomorrow. As I said, I'm Dr. Resnik. I'm the director of the MISH Institute. We have other people on with the webinar panel. First of all, Dr. Robert Malad. He's the 3DDX sales director. Robert does all the treatment plan with me at the MISH Institute. He works with 3DDX. He's very interesting in that he wears a lot of hats. He's actually a physician, OB-GYN specialist, He's also a dean of a college in California, and he also finds time to spend time at the MISH Institute helping us with treatment planning. So Robert will be basically running all the questions, and he'll be behind the scenes doing all the polls. Dr. Alabasi is our 3DDX implant team leader. He will be working with all the questions. So he'll be answering some of your questions. He'll also be asking me some of the questions during the webinar. We have Heidi Cartagena. Heidi is, a lot of you know her. She's the executive director of the MISH Institute. She's been with me from the beginning with Carl. Both her and I are from the original MISH Institute over 30 years ago. And she'll be on at answering any questions that you might have about any of our courses or anything dealing with the MISH Institute. And then we have Dr. John Connis from Chicago. He is our MISH Institute faculty director. He will be answering questions and also helping any doctors with any questions about the MISH Institute or any of the clinical questions. With that being said, 3D Diagnostics is basically putting this on. They've done all the reformatting on the CT scans. I've been with them now since the genesis of their company. It's over 15 years. They're based in Boston. They're one of the largest CBCT companies in the world. They basically do everything. I get all my guides from them. They have the new stackable guides. They do the full moth reconstructions. Now they actually do the prosthetic component. They'll help with the radiology reports. They have the co-diagnostic software. They also have the 3D printing. And also I see here now they also have the PPE. So if you need the N95 mask and face shields, I believe, Robert, can you explain this? Do they go on Shop 3DDX?
Yeah, so the link to order the PPE we have is shop.3ddx.com. We have the KN95 face masks. We also have face shields. And so they can go ahead and log in there and just place their orders. We have a promo code for the KN95 face masks. The typical price for a KN95 face mask is about $6. And they can get it for, if they use a promo code, it'll go down to about $4.75. So it's about,
oh, wow. Great. Okay. Thank you, Robert. Okay, let's go. We have a lot to go through. So let's talk about the first case. Case number one, one of our MISH doctors sent this case in. It's a maxillary edentulous arch, 65-year-old female. Medical history, osteoporosis, is a smoker, about a half a pack per day, and no known drug allergies. Medications, Prolia. So we have an edentulous maxilla. So right off the bat, I'm looking at, I always look at the medical history first, and let's see how any positive findings on the medical history could impact our treatment planning and treatment of this patient. One is osteoporosis, which is something that we need to look at, and also patient's a smoker. So let's go on a little bit further. Let's see the dental history. So the maxillary teeth were removed approximately 6 years ago. The patient's wearing an ill-fitting upper denture. If we look at the patient's chief complaint, they can't wear an upper denture and they want fixed teeth. So right off the bat, we know we're looking at a full arch prosthesis here, fixed. The doctor's concern is he wants to know how many implants and where do we put those implants. So let's do a couple questions first. First question, with respect to osteoporosis, what possible issues or complications may be possible with future implant treatment? Poor quality and quantity and quality of the trabecular bone, mottled cortical bone, medications which may result in healing complications, possible increased failure rate, or all of the above. So Robert, let's put up the question. Let's let our attendees answer. Let's see what our attendees get right here. So go ahead and answer A, B, C, D, or E. Robert will get a quick poll on that and we'll see what everyone answered. Oh, great. Perfect. I like that, 97%. So if we look at the correct answer, it's all the above. Anytime you have osteoporosis, you'll have poor quality trabecular bone and quality of the bone. It'll be very well impaired. The cortical bone will become mottled, and you can see those radiolucent areas within the cortical component. Most patients who are osteoporotic, they're going to be on medications. And unfortunately, a lot of those medications now given today result in healing complications. And because of the poor quality of bone, because of the medications, there is a slightly increased failure rate with osteoporotic patients that you have to take into effect. So if we look at what a CBCT looks like this is another patient I just put up. You can see where the trabecular bone is basically gone. It's very radiolucent. And here is actually a case study where a doctor had placed an implant in the posterior, went to uncover the implant. Because the poor cortical and trabecular bone, the implant actually was displaced inferiorly into a vital structure of the mandibular canal. So it does happen. You have to be very, very careful. If we look at how do we treatment plan these cases or surgically alter this, we're going to want to under prep. We're going to osteodensify these patients. So we're going to try to increase the bone implant contact with those patients. Also, when we prosthetically rehabilitate this patient, we're going to do progressive bone loading. So we're going to let it heal a little bit longer. We're going to let a little bit more time between appointments so that we take that poor quality of bone and increase it into a better quality of bone. Let's do another question. Is smoking a relative or an absolute contraindication? The patient is 1/2 packs per day. Remember, an absolute contraindication is you never do it. A relative contraindication is you can do it, however, you take certain precautions. So everyone answer either A or B, absolute or relative. Okay, Robert, what do we have? Perfect, 90%. Okay, it's a relative contraindication. So yes, if you look, I always try to get one of the most recent studies, and this is a study that was just published this year in 2020, where it shows an implant failure rate is 6 times higher in smokers versus non-smokers. Bone loss is 3 times higher risk of peri-implantitis in smokers versus non-smokers. Even though you have a higher implant failure rate and greater bone loss, if you explain to the patient that they do have this increased risk, that puts you into the relative contraindication. So certainly we couldn't, because there are so many smokers in the world today, there's no way that you could make that an absolute contraindication, unless the only exception would be is if they are a very, very high chain smoker, multiple packs per day, but that usually isn't the case. Third question, the patient's on Prolia for osteoporosis. What type of medication is Prolia? Is it a bisphosphonate? Is it a parathyroid hormone, anticoagulant, or is it a monoclonal antibody? Robert? Okay, so pick A, B, C, or D. Okay, what do we have, Robert? Okay, This is kind of a little trick question. Everyone thinks it's a bisphosphonate, but Prolia is actually not a bisphosphonate. It's a monoclonal antibody. What is a monoclonal antibody? It's a lab-produced antibody. Basically, it's antibodies that are produced in the lab. And Prolia is a little bit different than the regular bisphosphonates. The regular bisphosphonates that you're used to, the Fosmex, the Beniva, or the Reclast, those are used for osteoporosis. An alternative now is Prolia, denosumab, which is this monoclonal antibody, which instead of taking an oral medication, this is a subcutaneous medication, meaning the patient goes in twice a year, gets a sub-Q injection of this drug. So you might want to say, is this a relative or an absolute contraindication? So Prolia, what do you think, is Prolia absolute or a relative contraindication? Pick A or B. Then we'll explain exactly what to look for with Prolia. Okay, Robert, what do we have? Relative, very good. Relative is the answer. So if you look at Prolia, again, this is not a bisphosphonate. The problem with the bisphosphonates, the reason why we have so many issues, especially with the IV form of the Zometa form of bisphosphonates, is the half-life. Some people, it's over 10 years, and now studies are saying it's a lot longer than that. The good thing about Prolia is the half-life's only 25 days. So basically, it's in and out of the system relatively fast. My recommendation is it is a relative contraindication. I would send my medical consultation form to the patient's physician and let them make the recommendation on that. A lot of physicians will give the patient a little bit of a drug holiday, at least for a couple months, but it all depends on how many years the patient's been on Prolia. The longer they've been on, the more chance that they're going to give them a drug holiday. The less time that they've been on, the less chance that they will give a drug holiday on that. So good. So let's continue on. We want to do a 3D evaluation. So we look at this patient. You can see completely edentulous arch. The patient has lost some significant bone there. So not only have they lost buccal bone, but they've also lost bone in height. So usually the maxilla, because it's a thinner cortical bone, you will see, if you see where that prosthesis is, that's a wax up, and that's where the ideal prosthesis should be. You can see how much they've lost on that buccal plate, and then they've also lost vertical bone, which is very common in the maxilla. So we have our work cut out for us on this one. So if we look at this edentulous arch, as I explained last session, you always want to give every patient all of the treatment options. Even though this patient came in and asked for a fixed prosthesis, you want to explain all the other options. One option would be no treatment. But again, you make that into a positive. If you have no treatment, you're going to continue to have problems eating, you're going to continue to have bone loss, and you have to keep that same prosthesis, which you're going to not like because they're coming in for treatment. So obviously, there's something they don't like about that. The second is conventional denture, decreased mastication, bone loss. You tell them, yes, I can make you a new prosthesis, but you're probably most likely not going to eat that much better than what you have with your other one, but you will continue to lose bone throughout the process. And then we get to the third option, which is the implant. You always want to give the removable and the fixed, and you can explain that. The overdenture, which what we call an RP4, is completely implant supported, or it could be an RP5, which is completely soft tissue supported. And then the third, so here's the RP4. You can see if it's implant supported, we need more implants. but we can take the palate out. So a lot of patients will like that because they can taste their food better, they can speak easier, and they don't feel like they're gagging. Or it can be an RP5, which is a soft tissue supportive, but that's a complete denture. So that is very similar to what they have. It's just they have secondary implant support. And the third option of under the implant is the fixed prosthesis, which takes more implants, more support, and a little bit more extensive treatment because it's a fixed prosthesis. So when we look at this particular case, if I look at the CBCT pan view, I see that the patients had significant bone loss. You can see it in the posterior, the pneumatization of the sinuses. And you can see here in the anterior the irregular amount of bone resorption, especially on the ridge. So if I take a look at this and just put some possible implants in, we know that we're going to have to do some bone grafting because there's very little bone in that posterior area, and especially on the left side versus the right side. However, what I do see is some pathologies. So last session, we talked about pathology in the maxillary sinus, which in fact, we got a lot of great feedback on that. One of the future webinars we might be doing is just dedicated to the maxillary sinus and the pathology, but that will be in the future. But let's look at this patient in particular. So I made up some questions. On the right side, you see this inflammation, the gray area within the sinus. So again, the sinus should be black. Anything that's not black is abnormal, and that's what we call pathology. So is this pathology mild mucosal thickening? Is it a pseudocyst? Is it acute rhinosinusitis? Or is it a secondary mucocele? Robert, let's put up the question. So please select A, B, C, or D. And our answer is A, mild mucosal thickening. So let's do a differential diagnosis on this. Let's go through these one at a time. First, let's talk about B. It could be a pseudocyst, possibly it could be usually a pseudocyst always on the floor, which this is, but it's usually unilocular area that's associated more with around teeth. We don't see any teeth. So it could be an old pseudocyst, but it's not giving us that, that dome-shaped normal evaluation that we usually look for a pseudocyst. Is it acute rhinosinusitis? Most likely not. We're going to talk about acute rhinosinusitis, but that is where the patient would be having a lot of pain, difficulty, swelling, and you would have what is called an air fluid level, which would mean the sinus would be filled up with exudate or pus. And a secondary mucocele, this is a mucocele that's inside the sinus. It divides the sinus into two different cavities. Obviously, it is not that. So this is mild mucosal thickening, probably the most common type of pathology that we see in the sinus. Some studies show up to 60% of sinuses have some mucosal thickening. This patient is definitely most likely asymptomatic with this mucosal thickening. So if we look at the left side, this gives us a little bit more pathology. So what is this? Is it mild mucosal thickening? Is it a pseudocyst, acute rhinosinusitis, or a secondary mucocele? Robert, A, B, C, or D? Please pick one. Okay, Robert. And it is C. Very good. So C is It is acute rhinosinusitis. Now, why is that? Well, as I was saying, it could be mucosal thickening. I wouldn't call that mild, though. That would be more of a significant mucosal thickening because it's taking up at least a third of the maxillary sinus. It's certainly not a pseudocyst because it is not dome shaped, and it's not a secondary mucosal because that again would divide the sinus into two different cavities. So why would I call this acute rhinosinusitis? It has that historic air fluid level. So what is the air fluid level? The patient most likely had their CBCT taken while they were standing up, because what happens is the exudate or the pus will gravitate with respect to gravity. So the patient was standing up. So you see this clear demarcation line of what is called the air fluid level, and secondly, if you look at the opacity of this lesion, it's rather opaque. So usually in acute rhinosinusitis, the air fluid level, because it is exudate, it's not actually just inflamed tissue, will be slightly more opaque. So this patient most likely has some pain on the left side. Usually the patient will complain about pain when they have this air fluid level. And this is something that needs to be treated with antibiotics and or an ENT. Next question. If we look at this CBCT, if you look at that panoramic view up there, what's wrong with this scan? Could it be the voxel size is too small? There's motion artifacts within the scan. The scan does not show the maxillary ostium, or there is extensive beam hardening. So Robert, let's put up the question. And the answer. Okay, good, almost 70%. C is the correct answer. So why is C the correct answer? First of all, the voxel size has to do with the contrast and the clarity of it, and that's a pretty clear scan, so that wouldn't be it. Motion artifacts is when the patient moves during the scan and you see like a double image. So we're not seeing a double image, so I wouldn't say there's motion artifacts. Beam hardening is always seen around a metallic object, such as an implant. That's those radiolucent lines that you will see next to an implant that a lot of people think that it's bone loss. It's actually just beam hardening from the CBCT. The answer is C, does not show the ostium. So if you recall, at last session, we talked about the ostium. The first thing that will happen is if you send this patient to an ENT, the ENT will open up this scan and they will see that you didn't take it high enough. And they'll tell the patient immediately they have to go get another scan. It all depends on the patency of that ostium. So that ostium has to be patent. If it's not patent, then the ENT actually has to go in endoscopically and open it up. So this scan was taken too low. So if you remember from the last session, always take the upper limit of a scan if you're anywhere near the maxillary sinus, meaning anytime you're going to place an implant near the maxillary sinus, make sure the upper limit of the scan is at the inferior border of the eye, inferior border of the orbit. And that will show us the maxillary ostium, which we have to verify that's patent. So if this scan would have been taken up high enough, the ENT would have looked at this and verified that it was open. If it was open, they would most likely treat this patient with an antibiotic. If it was not patent and closed, they would schedule the patient and go in endoscopically through the nose and clean out the ostium in conjunction with antibiotics. So again, get those scans higher so that doesn't happen. As I told you last time, I've done, this is an area of interest for myself and also my good friend, John Suzuki. Dr. Dean Suzuki ran the perio program at Temple for many, many years. Now he's chairman of the FDA. But over many years, we probably, John and I did almost 10 studies in the sinus. Melody Choi here did actually 3 studies that are all published in the maxillary sinus. And I just want to share one of them with you. These are patients who came in the Temple University Perio Department that were getting sinus elevation surgery. And 37% of them exhibited pathology that were asymptomatic. So that just shows you have to look at this maxillary sinus pathology. And she's also done prevalent studies on septum and also in the mandible, the vascular canals. So again, she's done 3 of them, and thank you, Melody, for all the hard work you've done. And I thank you, John, for putting all those together. So let's continue on. If we look at the maxilla, we have something that's called the nasopalatine canal. Also, some people call it the incisive canal. So what is this canal? This canal averages about 10 millimeters in length. And this canal can impact our placement of implants. So we always want to look at this in different views, cross-sectional, sagittal views, etc. Because there's a nerve in there, the nasopalatine nerve, and the sphenopalatine artery that come up through that canal. And certainly if we put an implant too close to that, we can end up with issues. Number 1, bleeding. Number 2, pain. And or 3, we can have a non-integrated implant because we're putting an implant into soft tissue. Remember, our implant, we need bone implant contact all the way around the implant. But if you get too close to this canal, it can impact the success rate of that implant. So we want to evaluate where the foramen is, and this is also called the nasopalatine foramen. Most people call it the incisive foramen, and in this particular case, it's actually rather large. So if we look at placing implants in here, this one is rather large. Okay, it's probably about 10 millimeters. Most of them are about 6 millimeters or less. So this one's pretty significant. Why? If it is that large and it impacts our implant, it can cause problems. This is Richard Kraut's study. It was in the late 90s, and he found that 4% of incisive canals were too large to place an implant in either the 8 or the 9 position. Now we do the bone grafting, or it's predictable enough that we can graft around this, but a lot of these nasopalatines and incisive canals are very, very large. So you have to be very careful with that. Another anatomic, what I would call variant on this scan, is what we found was this structure, and it's this radiolucent little area on this cross section in the cuspid area. Could it be the nasopalatine canal? Could it be a median vascular canal? Could it be a canalis sinuosus? Or could it be the greater palatine canal? So Robert, let's put the question up. And please select A, B, C, or D. Okay, Robert, let's see what everyone. And okay, so let's talk about this. The answer is C. It's a canalis sinuosus. So if we look at why it is a canalis sinuosus, it is a canal, which is a, let me go to the next slide, actually. Let me go back. Okay, let me explain this one. Then I actually have another question for you. The nasopalatine canal is in the midline, so that would not most likely be in the cuspid area. The median vascular canal is in the mandible. The median vascular canal is the anastomosis of the right and left sublingual arteries. So that's right in the midline of the mandible. And the greater palatine canal is posterior. So what is this canal synostosis? Well, let's go to the next question and then we'll answer that. What nerve is in this canal which may predispose to implant placement issues? Is it the anterior superior alveolar, the middle superior alveolar, or the posterior superior alveolar? So this is something that we never even knew existed until we started taking CBCT surveys, and we would see this canal in a good majority of our patients. And some of these are rather large. So it has a nerve in it. Which nerve would it be? Okay, almost. It is A. It's the anterior superior alveolar nerve. So let's see why is A the correct one. We have V2, maxillary nerve, gives off a branch, the infraorbital nerve. The infraorbital nerve gives off the branches of the superior alveolar nerves. And the anterior superior alveolar innervates the incisors and the canines, plus the soft tissues of the maxillary sinus in that area. So what actually is this canal synostosis? It's a canal which carries this anterior superior alveolar nerve. And why is that problematic? Well, if we're putting an implant in this area, in the canine lateral area is usually where it's at, we're putting it in the soft tissue, and some of these canals can be rather large. So you can see here by the green arrows that I have marked. Here's another one or another view of it on a sagittal view. And in this study, the prevalence of this on CBCT image is about 35%. So about 1 in 3 patients, you will see this. Why is this significant? Well, here is a case study, 2016 case study. Implant was placed in the lateral position into the canal synostosis. Patient ended up with severe post-op pain, and there was extensive hemorrhage during the surgery. Now, this is, I would call, a very remote possibility. You don't see it that often. Like I said, we never even knew it existed until we started seeing all these CBCTs and evaluating it. So in the future, just look for this radiolucent canal. Some are rather large that can be pretty significant. So look for those on the CBCT, and it's usually the anterior superior alveolar area. Next question. Here is a cross section, and I have this marked with a green arrow and a red line. What anatomic structure is this in the lateral wall of the maxillary sinus, which can complicate our lateral wall sinus surgery? Is it the intraosseous anastomosis, extraosseous anastomosis, a nutrient canal, or the infraorbital foramen? Robert? Okay, A, B, C, or D? Just select one. Robert will give us. Okay, the answer is A, intraosseous anastomosis. Now, why is that an intraosseous anastomosis? If we look at the other options, there is an extraosseous anastomosis, but that is in the soft tissue. This is within the bone, so intra within the bone anastomosis. It could be a nutrient canal from one of the nerves, but usually it won't be that large and it won't be that significant in the lateral wall. Infraorbital foramen would be, this is very low. Usually the infraorbital foramen is about 6 millimeters below the infraorbital rim, and that is way low. So the answer is A. So what is the interosseous anastomosis? It is the posterior superior alveolar artery and the infraorbital artery. And these two arteries anastomose in the lateral wall of the maxillary sinus. So why are we even talking about that? Again, this is something we didn't know too much about until we got CBCT surveys. And now the studies here, this study is showing us about a 56% prevalence on CBCT images. But right below it, if it's greater than 1 millimeter, it's about a 132% chance of having excessive bleeding. So this is a common complication that I hear doctors call me about. You know, they make their lateral wall and they're getting a lot of bleeding once they make their osteotomy cuts, and it's from this artery or anastomosis. So usually when they're greater than 1 millimeter, they're significant. And this one is certainly greater than 1 millimeter and would be a significant issue or something you should be concerned about beforehand, so you're prepared for that. If you want to know how to treat that, I have a section in the complications and also the new surgery book on different ways to counteract that if it does hemorrhage on you. Next evaluation, always evaluate interocclusal space. Remember, the patient's coming in for a prosthesis that needs to be aesthetic and have longevity and success. So we need enough interocclusal space. In some of these maxillas, we run out of room to make the prosthesis. So you have to make sure you have enough interocclusal space to make the prosthesis. So let's see, what does the literature state? Next question. What is the minimum amount of interocclusal space required for a cementable fixed prosthesis? Now, how do I define interocclusal space? From the bone level, which would be the top of the implant, to the incisal edge of the prosthesis. Is it approximately minimum 4 millimeters, 6, 8, or 12 for a cementable fixed prosthesis? Robert? Please pick A, B, C, or D. And good, C. C is the correct answer. So let's go through and talk about that. So if 8 millimeters is, for many years, has been talked about for cementable fixed prosthesis because you need minimum of 5 millimeters for retention and resistance form on the abutment. And then you need 3 millimeters of prosthesis material. So whether if it's a metal, porcelain fused to metal, or now with the zirconia, it can actually be a little bit less. So some people talk about 7 millimeters for zirconia, but usually it's 8 millimeters, and that will include the porcelain fused to metal. Next question, what is the minimum amount of interocclusal space required for a screw retained fixed prosthesis? Approximately 2 millimeters, 5 millimeters, 8 millimeters, or 12 millimeters. Okay, so please, everyone pick A, B, C, or D. And Robert? Our answer is B. Very good. So as you know, you need less room for a screw retained prosthesis. And actually now with the zirconia prosthesis, some people will say 4 millimeters is the minimum. So ideally, when you get down into the 4 and 5 millimeters of interocclusal space, not only do you have to worry about technical complications such as screw loosening or fracture, but you also have to look at aesthetic issues. So it is true a screw retained prosthesis needs a lot less, but you have to be very careful. And with the advent of monolithic zirconia, it has really decreased the amount of space, but again, we still need the aesthetic aspect of it. So this is what the literature states, about 8 millimeters or 5 for a screw retained. So let's keep going. How many implants do we need on this case for fixed prosthesis, and in what location? So if we look at the highest failure rate of a prosthesis, if you look at maxilla versus mandible, significant maxilla over the mandible. So maxillary prostheses have a lot more failure rates than the mandible. A lot of the problem is because of the bone quality and treatment planning. The mandible is a whole different animal than the maxilla. So this goes back to the 1980s. Dr. Carl Misch came up with evaluating the residual ridge arch form and the dental arch form. So what do we mean by that? Well, there are 3 types of arch form, and this is called the dental arch form, meaning the prosthesis. It could be a square, it could be an ovoid, or it could be tapering. And how do you determine that? You look at a line that goes from the tips of the cuspid to the facial aspect of the central incisors. So the square has a rather significant, very small space from the tip of the anterior teeth to that cuspid. Whereas if you go all the way to the tapering, it's a larger space. So what is significant about that? That is all the cantilever. So when we look at this, let's look at this particular case though. And this is the diagnostic wax up of this case. So if you look at what is the arch form on this patient, if you look at, here's the tip of the cuspids to the anterior part of the number 8 and 9. So is it either tapered, is it ovoid, or is it square? So Robert, let's put that question up. So is it A, B, or C? And the answer is square. Very good. Excellent. It is square. So as you can see, that there's very little distance from that anterior facial aspect of those number 8 and 9 to the cuspids. Why is that good? Because now we don't have that anterior cantilever, and we'll get to that with the treatment planning. So what I had 3DDX do is I had them take the same case and make a tapered arch form prosthesis. I just gave you the answer. So we'll go through this one. This one is actually a tapered one. So you can see the red area, which is the nasopalatine. Look how far to the anterior the facial aspect of number 8 and 9 are to the nasopalatine. So it's a tapered arch form. And why is this significant? Because when we look at this image here, where I have superimposed the tapered versus a square arch form, and you can see how much of an anterior cantilever that is with the tapered arch form. So with the square arch form, hopefully you can see this, the bone underneath is a translucent area, and then you can see the outline of the teeth. There's not much of a discrepancy between the residual ridge arch form and the square dental arch form. Whereas on this one, same dental arch or the residual ridge arch form, but look at how much that is cantilevered out to the facial. So it's a huge tapered arch form, which is really significant. So this is a larger cantilever, With that being said, the worst or the most non-ideal arch form is a tapered. We need more implants to counteract that anterior cantilever. Whereas a square arch form, we need less implants. So if you follow Dr. Carl Misch's key implant positions, we know that we always want implants in the cuspid. We know we want them in the posterior and then sometimes in the anterior. So let's look at these key implant positions and let's go through them one at a time. The first key implant position is the canine. We always want implants in the canine area for a fixed prosthesis. Why is that? Next question. Why is a cuspid implant position crucial to the long-term success of a maxillary fixed prosthesis? Is it because a cuspid position has more bone? Cuspid position has increased bone density? It's required for stress distribution because of canine guidance and mutually protected occlusion? Or is it more ideal for aesthetics? So question is, or answer, is it A, B, C, or D? And the answer is C. Very good. Excellent. 87% got C right. C is the correct answer. We always want an implant in that canine area because of canine guidance. If we have a group function or a balanced occlusion, what happens is it puts a lot more force on the temporalis and the masseter muscles. The patient's biting force increases. We have eccentric contacts, shear forces, not the most ideal. So for a fixed prosthesis, remember, the number one area that's most crucial is that canine area because we're discluding it off of it. It's the same reason why the longest root in the upper and the lower jaw with natural teeth is the maxillary canine area. So very good. Our second key implant position is the molar position. So why do we want one in the molar position? Why do we need one molar? It has more bone, increased bone density, aesthetics, or it absorbs higher posterior forces to prevent a cantilever effect. So Robert, next question. Is it A, B, C, or D? And our answer is very good. Excellent. D. 99% of you got it right. Why is that? Well, remember the amount of force, the ratio is 5:1, the molar to the anterior. That's why the surface area of the molar is so large. Also, if you look at the molar to the premolar, it's 2:1. So we want something back in the posterior to counteract the forces. So here's a case that's rather interesting, that you can see this large cantilever, and it's a rather significant cantilever. And patient is biting more in the posterior than in the anterior. So that is all the shear force, and you can see all the resultant bone loss around that. But what amazes me is the cusp design. Remember last session we talked about minimal cusps, and you can see, look at how those large cusps, meaning lower plunging cusps, are hitting into that, which gives us the shear force, which results in crestal bone loss. Not a good situation. So one of the key criteria for minimizing maxillary prosthesis failure is to minimize the cantilever effect. And then also, because in cases where we have significant parafunction or more force needed, we want one in the premolar area. Usually this is second premolar, the further posterior, the greater counteraction of the force. But if the bone isn't of quality or quantity in that area, you can put them in the first premolar. So let's go through a summary of this case. So we're going to put 6 implants in, the canines, the molars, and the second bicuspid. So if we look at number 3, we have 5 millimeters of host bone below the sinus, and we've treatment planned this. We can put a 5x10. Usually we want a 5 millimeter implant in the posterior. Remember, it's a molar tooth, so we want a wider diameter tooth. And if you're going to do a lateral wall, you can most likely put a 10 millimeter implant in. If you're going to do a crestal approach, you want to put only about an 8 millimeter in. Remember, a crestal sinus graft, we can predictably grow about 3 to 4 millimeters of bone. We go any more aggressively than that, and now we're getting into membrane perforations and complications. So you can either do it lateral wall or crestal. Number 4 is the same. Number 4 is a bicuspid, so we want a little bit less diameter, 4.3. I'm using the Hahn system here. So 10 millimeter would be for lateral wall, or an 8 millimeter would be for crestal. So on the right side, whether you do crestally or lateral wall, you have that ability. In number 6, we have some nice bone there. We can get a 4.3, which is a nice wide diameter implant by 10. And it looks like we have some cortical bone and pretty good trabecular bone. So 6 mil, number 6 will be right in the site. Number 11, we have a little bit more narrow bone there, but we can still get a 4.3 by 10 in. Might graft the facial aspect a little bit just to beef that up. But you can see the outline of the prosthesis, so we're right in the ideal position. If we go to the other side, number 13, we're looking at a lateral wall or crestal again, 10 millimeter for a lateral wall, 8 millimeter for a crestal approach. And then if we look at number 14, we only have 2 millimeters of bone. So on the left side, we are definitely going to have to do a lateral wall. There is no way that you can get or you should put an implant in with that little bit of host bone. So you're going to want to do a lateral wall with this particular case on the left side. So I would do 13 and 14 with the lateral wall. So in summary on this case, when you're treatment planning these maxillary prostheses, especially if they're against fixed dentition, you want, if it's a square arch form, you can do 6 implants. If it's an ovoid, we're going to add 1 in the anterior to counteract that anterior cantilever. And if it's a tapering, then you're going to want to possibly add 2 in that area. So that is a summary of the case. With this particular case, because of this pathology, I would, number 1, I would get a new CBCT, higher CBCT, determine if the maxillary ostium is patent, and this patient would go definitely to an ENT. Most likely, if the ostium's patent, the ENT would clear this patient after a course of antibiotics, and also prior to your graft, you're going to give prophylactic antibiotics, which would decrease the inflammation and any infection in that area. But definitely with the rhinosinusitis there, that patient should see an ENT after you determine if the ostium's patent. So, Dr. Alabassi, do we have any questions on case number 1?
Yes, Dr. Resnik, first of all, thank you for the very interesting case. We do have a question regarding the canalis cynosis. If you do have a canalis cynosis, a big one in the cuspid area on your CBCT, what would you do about it? Would you not place an implant?
Very good question. To be honest with you, I've been doing implants for 32 years, and I've seen a large one where it would actually impact the position of that implant probably less than 5 times. They're usually so small that you can alter the positioning either anterior or posterior to it. A lot of times, the most common area I've seen them to be in the cuspid area. A lot of times they're in the lateral areas also, which are a lot of, in most of the cases for fixed prosthesis, we're not using the lateral area. But what I would do, I've never actually seen a case where they have had chronic pain or any type of neuropathy, but that is one case study that I did find in the literature. So to answer the question, I would modify the position, either anterior or posterior, and you could do that very easily without detrimental effects to the prosthesis or the placement, because it's so small. It's a small canal.
All right. We did get a couple of questions regarding removing the contents of the incisive canal, or not removing the contents and grafting around the nerve.
Yes. Okay.
What are your thoughts about that, Dr. Resnik?
Yes. So it's interesting. In the first 3 surgery books, we had that as a procedure that we would do all the time. In fact, if you look at Brandmark's 1985 Tissue Integrated Prosthesis book, the first book on implant dentistry, he describes putting incisive canal implants in. We taught it for many, many years. We kind of got away from placing implants into the canal because of how predictable bone grafting is now. I mean, we don't have to take the large blocks like we used to. So now we take the smaller, do the membrane grafting, and it's so predictable we don't have to go in there. But for this new book that just was published, I actually didn't put it in until the last minute. I added it at the last minute because there are some indications to do it. If you look at the success rates are very high. Complications are very low. Some people talk about complications with nerve issues and bleeding. I really haven't seen that to be a significant issue. So if you look at the studies, they do have very good success rates, and it is a procedure. What you have to do is you have to make sure you get all the contents of the sphenopalatine and the nasopalatine nerve out. And then you want to put an implant in that engages all the walls. If it is in the textbook, if you want a step-by-step process, it is in this new 4th edition protocol. I actually have a case show you step-by-step.
Fantastic. We did get a couple of questions also regarding, or basically asking, why not Alum 4 or 6, and why not tilting implants to avoid sinus lifting?
Okay, we still teach Alum 4, we still teach angled implants. In this particular case, there was just not enough room. The maxillary sinus went almost up to the, including the first bicuspid area. And because of the square arch form, we had a more predictable anterior component, but the posterior had very little bone. So you would be cantilevering a pretty significant area there. Secondly, it was opposing, I believe it was opposing natural teeth. So we have higher force factors. When we do that, we try to put more implants in a more ideal position. If it was low force factors, better bone quantity and quality, certainly an Alum 4 would be an option if we were able to get the angled implants in.
All right. Would you like to continue with questions?
Yeah, let's, that was almost an hour. It wasn't over an hour. So let's get going. People are busy. So let's get to the second case here. Second case, we have a 60-year-old male, controlled hypertension, history of AFib, on lisinopril and Pradaxa. The chief complaint is the patient wants implants to hold my denture in. And the doctor's concern is, where do I place 2 implants for an overdenture in the mandible? So let's first look at some of my potential complications. Controlled hypertension, we talked about that last time. You're going to want to do a stress reduction protocol, see these patients early in the morning possible sedation, monitor their vital signs, make sure that they are truly controlled. AFib is more of an issue. The red light goes off when I see that because they're going to be on some type of blood thinner. And they're on Pradaxa. So first question is, what is Pradaxa? It's an anticoagulant, antihypertensive, bisphosphonate, or a biologic medication. A, B, C, or D. Please pick the answer. And Robert will get us polling on that. Okay, Robert. And A is the correct answer. So Pradaxa is one of the new thrombin inhibitors. This is a drug, if you look at these new thrombin inhibitors, a lot of physicians are taking the patients off of Coumadin and putting them on these new thrombin inhibitors. They work very well. They don't have to be monitored like they do on Coumadin. So there's a lot of advantages, and there's very few side effects like some of the Coumadin derivatives. So let's go and let's talk about this Pradaxa. What precautions should be taken surgically when a patient is on Pradaxa? You want to use a good surgical technique to prevent bleeding. You want to use hemostatic agents. You want to use a good suturing technique to keep the incision line closed. And you want to minimize the extent of surgery, meaning you're only going to want to surgerize one area, either the maxilla or the mandible, and you wouldn't want to do both arches or all the above. So Robert, let's put up the answers here. So please pick A, B, C, D, or E. And the correct answer is very good, all the above. So let's talk about these. This is a chart that I have in the textbook, and if you look at the last three, those are the new novel treatments for AFib. Xarelto, Eliquis, those are factor 10 inhibitors, and then Pradaxa is a direct thrombin inhibitor. What is good about these compared to Coumadin, which is right next to it, is that, like I said, you don't have to have your INR, you don't have to have testing, and it is really does not have any dietary constrictions, to where Coumadin, you have to watch what you eat, you have to watch what medications you're on. The problem with these drugs is the patients are going to bleed more. And even though that most of these are taken off, usually 1 to 2 days, sometimes 3 days before, ideally, physicians want the patients back on them as soon as possible. So you put them back on. So there are some cases where patients will go back on right after, maybe within 24 hours, and then they get a post-operative bleeding episode. So you have to be very careful with this. Certainly you want to get a MD consult on this. And remember last session what we talked about. You never ever have the patient taken off the medication. Let the physician remove them. Let the physician put them back on. If the patient calls and tells you, the physician told me, you know, it's up to you, you put it back in their lap. You never want to alter one of these medications. Let the physician, it's their medication, and they're responsible for monitoring these patients. So make sure you do an MD consult in writing on this and let them alter the patient's medication. So let's look at a 3D image of this. So here is the lower jaw. You can see a lot of bone. We have had some significant buccal bone resorption. You can see how it's resorbed from the buccal to the lingual. The patient's becoming more of a skeletal class 3, which does happen when the patient becomes edentulous. If you look at a 3D model, good bone quality, but it is resorbing. So if we go through the different treatment options, again, we're going to do no treatment, as we said before. We're going to do conventional denture would be the second option. The third option is going to be either removable. We talked about this for the first case, RP4 or RP5, and or the fixed. So if we look at the patient's chief complaint, they want some implants to hold my denture in. So it appears that they don't mind having a denture. So the patient probably most likely wants an overdenture. The doctor's concern is, where do I place 2 implants for an overdenture? And when I see this, I just want to make this point. You have to be very, very careful on 2 implant overdentures. 2 implant overdentures are successful, but there's a lot of them that are not successful and lead to a lot of issues with patients. So what do I mean by that? Well, you know, right off the bat, we looked at this case, and if you look at the amount of bone, you can almost do anything on this case because there's so much bone. But the doctor is looking to do 2 implants for an overdenture. So what I always like to do is use this analogy. And what you want to do is explain to the patient, Mr. Smith, we can do 2 implants. It is like a 2-legged chair. And yes, they do actually have 2-legged chairs. I found that on the internet. They sell that, believe it or not. But a 2-legged chair can be stable if you stabilize it, but you can move it back and forth if basically you chew on it. So 2 implants is like a 2-legged chair. It will give you some support or retention, but it's not going to give you the retention possibly that this patient needs or wants. A 3 implants is like a 3-legged chair. So it's going to be stable. However, if the patient just bites down just in that one position, it might move a little bit. And then they come back and they say, okay, I thought I had implants, and why is my prosthesis moving? A 4-legged chair is more like a fixed prosthesis. It's 4 or 5 implants where it's not really going to move because the AP spread's large enough. But why do I want you to get used to doing this when these different treatment options is because you need to, the patient does not understand it. They're coming in for a prosthesis. They don't understand the biomechanics of 2, 3, or 4 implants, such as this. So this is a 2-implant overdenture. So if you look at it, when the patient bites down, they have a posterior component that's going to move. It has to, because it's on soft tissue. It's soft tissue supported. But they have an anterior component also. So it fulcrums on these implants. So a lot of these will move back and forth. The attachments, you might have had a case like this where the attachments wear out rather fast. And it's because you have this anterior and posterior cantilever. So when you look at the 2-implant prosthesis, go back, and if the patient says, okay, I only want 2 implants, explain them. Okay, 3 implants is going to be a little bit more stable. 4 is going to be even better. So if they come back and they complain about the 2-implant overdenture, and they say, I don't like this, it's moving, then you can put more implants. But now you're actually the patient will be actually paying for those implants instead of you possibly putting implants in at no fee because the patient's not happy. So that leads us to the question. We talked about the 2 types of prosthesis, the RP4 and the RP5. What is the major difference between an RP4 and an RP5? An RP5 has no palatal coverage. Patient satisfaction is greater with an RP5. RP4 has no tissue contact, whereas an RP5 is primarily soft tissue supported. RP4 requires less implant support, meaning less implants. So Robert, A, B, C, or D? Let's go ahead and see what we have. A, B, C, or D? Okay, what's our polling say? Yes, C is the correct answer. So let's see, why is C the correct answer? Number one, RP5 on the palate does have palatal support. So it's soft tissue supported. You definitely need palatal support. Patient satisfaction is greater with an RP5. No, it's RP4, it's smaller, and because there's no soft tissue support, the patients are always happier. They can still get sore spots with an RP5. RP5 has no tissue contact, whereas an RP4 has no tissue contact, whereas an RP5 has primarily soft tissue contact, which is correct. So RP4 is totally implant supported, RP5 soft tissue supported. And RP4 requires less implants. No, needs more implants because it's all implant supported. So just one additional aspect of this, if the patient comes in and they have a posterior ridge form on the mandible, that they're getting a lot of sore spots, you want to probably talk them out of a 2-implant overdenture, because why is that? They have to, if you look at the primary stress bearing area on the mandible is the buccal shelf. So you need a buccal component to that. So if you look at that prosthesis on the top, that's an RP5. It doesn't even go near the soft tissue. It's completely implant supported. So the patient gets, because of poor posterior ridge form, they don't have a lot of support there. They're going to get more sore spots. Another indication for an RP4 over an RP5, patient comes in, they have xerostomia. You never want to do an RP5 on a patient with xerostomia. Why? Because it's soft tissue supported. Now you're going to put implants in, but they're still going to have the same problem, because without the fluid in their mouth, the saliva in their mouth, they don't have that buffer between the prosthesis and the tissue, and they're going to be more abrasive to the tissue, and they're going to complain more of most likely complications. So again, the RP4 doesn't need the buccal shelf. It's all implant supported, where an RP5 needs good peripheral extension. So this is the treatment option form that I use. It's in the textbook, and what it does is it explains all the patient's options, and I'd like you to start using this. One thing I really recommend, and I get a lot of positive comments about it, is if you look at C or D, I have phases. So you give different phases and you give fees for those phases. So the patient's not coming back, and everyone's had this, after phase 1, the implants are in or the bone graft's in, and they come in for their suture removal and they want to know when their prosthesis is going to be put in. Okay, if you give it to them in writing and it's clear like this, they understand the time frame on it. Secondly, it gives the advantages and disadvantages of each one of those prostheses. So if the patient says, okay, I just want a conventional upper denture, and they come in after you make the denture and they say they can't eat or speak, we say, Mr. Smith, I explained this to you. That's why we gave you C or D. Now they can upgrade, but again, you're not paying for that, and now you allow the patient to pay for it. So you have to know these advantages and disadvantages. That also is in the textbook, and I have the literature that it states. So if you want to talk about biting force, if you want to talk about speech difficulty, here's a study. 88% of people with complete upper dentures have speech issues. There's a citation for it. So you can show that to the patient, and I highly recommend you get into using these type of treatment plans in writing. So let's, we're running out of time here, so let's go. Let's talk about implant position. Dr. Carl Misch in the 1980s also came up with the mandibular positions, A, B, C, D, or E, interforaminal distance. So if you look at the interforaminal distance between the mesial aspects of the mental foramen, males, it's about 42 millimeters, females, about 40 millimeters. So no matter what, even if there's usually an anterior loop, you can get 5 implants in that area with 3 implants between each implant and 2 implants in front of the foramen. So this is an ideal area. Usually we have enough bone in this interforaminal distance to place 5 implants. So if we have 5 sites, what are our sites for an overdenture? We can put them in B and D. B and D is the ideal option for 2 implants. That decreases that anterior cantilever and it puts more stress on the buccal shelf, but the buccal shelf is where the cortical bone is parallel to the occlusal force. It's made to withstand the force. So you won't get that fulcrum effect. So the B and the D position is ideal. A, C, and E is one of my more favorite positions. Why is that? Because you have that C implant, so it increases our AP spread. So it has that implant towards the anterior. Whereas an A, B, D, E implant, we have more implants. However, our AP spread is more of a straight line. So that C implant is more ideal, in my belief, than having the A, B, D, E. Or you can do all 5 implants and then you have the best. And that would give you the 4-legged chair the most support. So you want to go through this. Again, give the analogy. Implants in the posterior, can you put them in? Possibly. But for an overdenture, usually we're not doing that. You don't really need implants in the posterior unless possibly you were doing an RP4 or there was a site in the anterior that was complicated because of some anatomic variant or some bone issue, bone quality or quantity. So let's keep going. We want to look for an anterior loop, and I get this question all the time. Let me show you how to determine where and how a anterior loop is determined on a CBCT. Is there an anterior loop here? It's very hard to see from a 3D image or a cross-section image. So let's first talk about what is an anterior loop. Is it the extension of the mental nerve anterior to the mental foramen? Is it extension of the incisal nerve anterior to the mental foramen? Is it the extension of the mental nerve anterior to the mandibular foramen, or is it the extension of the incisive nerve anterior to the mandibular foramen? So let's go ahead, Robert. Is it A, B, C, or D? Okay. And A is the answer. So A is, it is the extension of the mental nerve. Remember the anatomy of this nerve. The mandibular nerve, V3, the inferior alveolar, will enter the mandibular foramen by the lingula on the lingual surface of the ramus. It transverses anteriorly in the first molar, second bicuspid area. It splits into 2 terminal branches. One is the mental nerve, which goes through the mental foramen, which gives us the sensory, soft tissue sensory innervation. And then the second terminal branch is the incisive nerve, which goes into the anterior mandible, which innervates and gives the nutrient canals to the actual anterior teeth. So it's the mental nerve, and it's that component that's anterior to the mental foramen. So if we look at, here's a recent study, 2019, CBC study reported, what is the prevalence of an anterior loop? A, 5%, B, 10, C, 25, or D, 60%. So go ahead, pick A, B, C, or D. Okay, so C is the correct answer. So we have 48% of our doctors. C is the correct answer. This is in accordance with a lot of the other studies out there. So most are about 25% out there. There are some that are higher. A lot of the higher ones were made off of panoramic, 2-dimensional Panorexes. Be very careful of those. You want to look at the CBCT studies. The length was 1.63 millimeters. So it's not much. It's rather small, 1.6 millimeters on this particular study. Next question. What CBCT image is, hold on, Rob, okay, is most accurate to determine if an anterior loop is present? A cross-section, a panoramic view, an axial view, or a 3D view? What is the easiest way to determine anterior loop? A, B, C, or D? And our answer is, okay, most people pick D. 3D is not the most ideal. So if we look at this, why is the axial? Well, the 3D only shows us a 3D image. It doesn't show us inside of the actual mandible. And the incisive, the mental nerve is in different planes, meaning it transverses anterior to what is called the mental canal. The mental canal then goes from the mandibular canal all the way up to the mental foramen. So they're in different, basically, planes. So I like to use the axial view, and I'm going to show you how to use this. So first you go right above the foramen. So if you look at the 3D image on the right, I have that blue, that green line is where the level where I'm at. And I make a line at the anterior part of the mental foramen. And all I'm going to do is click 1 millimeter inferior at a time. So here is the first millimeter. So now you can see the nerve, which is highlighted in pink there. So the mental foramen nerve component is highlighted, and the inferior alveolar body, because it's in different planes, you're not seeing all of it in one plane. So now as I go inferior, I'm going more inferior, and now we're seeing this is an anterior loop. So you can see as I go inferior, you're seeing this pink area, and it's anterior to that green line. So that means that there is an anterior loop there. So let me show everyone that once again. You're going to start superior to the foramen. You're going to go inferior. Usually every click is 1 millimeter. And now you can see where the nerve is at the level of the mental foramen. But as we go inferior, because the nerve is coming in inferior below the canal, and then it is anterior and exiting in a posterior direction. So this part of the nerve that is anterior to the mesial or the anterior aspect of the mental foramen is in pink. Okay, and again, I have that well documented in the book to read that. That's a little bit complicated, but that is definitely the best way to determine an anterior loop. We always want to look at interocclusal space. Interocclusal space is very important with an overdenture. Now let me explain why. First, how much interocclusal space is required for an overdenture when you have independent attachments? So if you look here, I have locators. So from the ridge to where the incisal edge is it approximately 4 millimeters, 9 millimeters, 14, or 16 millimeters? So what is the minimum amount of interocclusal space for a, in this case, a locator attachment, which is the lowest profile attachment? Okay, Robert? Okay, B is correct, 9 millimeters. Now, let's talk about this. If you look at, let me see, I have, yeah, here it is. So if you look at the studies, a locator is the lowest profile attachment. What a lot of people don't realize is that you need, on the buccal and the lingual space. So you have to be very careful. So if an implant's positioned like to the facial, you need at least 2 millimeters of acrylic to hold that attachment in. So if that implant is too facially or too buccally or lingually inclined, you're going to have an issue there too. But height-wise, you need about 9 millimeters for the male and the female attachment, and 2 millimeters of basically biologic width for the implant area. Now with other attachments, so if you talk about O-rings or ball attachments, you need more. Now you're up to 10, 11, sometimes 12 millimeters, because those are not real low profile attachments like the locator. How much is needed for a bar retained? So we're going to make a bar. We need anywhere from 6 to 8, 8 to 10, 12 to 15, or 16 to 18. So please pick A, B, C, or D. Okay, Robert, let's see what we have. Very good, excellent. 68% of you got C. Depending on what type of bar, most of these are titanium now. They're not, we used to do gold type 4 alloy bars, but now titanium milled bars are the most common. And most commonly, they're either a clip, like a Hayter or Dolder clip, or a locator attachment. But most are about 12 to 15 within that range, depending on what type of attachment that you're going to use. So again, as you can see, if you're going to make a bar, you have to make sure you have enough interocclusal space. So that leads us to the question, how much osteoplasty do we need? If we're a restorative dentist and not doing the surgery, what do we tell the surgical doctor? Well, here is a very important concept that you need to know, and it will make the prosthetics very, very easy. So basically, when you have a overdenture, you need more room, and then a fixed prosthesis. So you want to make sure that you take enough bone away during the surgery procedure. So an FP3, which is a fixed prosthesis, you don't want that vertical cantilever because it's fixed. So you want to do a minimal cantilever. However, for an RP4, RP5, you want to get a very aggressive osteoplasty within normal limits. So when you look at this treatment plan summary, whether we do BD position, whether we do ACE or ABCD or ABCDE position, we know we have to do an osteoplasty on this case because it's a very thin ridge and we need the space. So you're going to have to do an osteoplasty. But if it's an overdenture, make sure it's an extensive osteoplasty, because the more room you have, the easier the prosthetics. Now, another little trick here, or a possible complication that you can get in, is a lot of doctors will do an osteoplasty like this. They'll just osteoplasty from foramen to foramen. And what does that do? It leaves us a large volume of bone posterior to the foramen. We don't want that, especially if we're making a bar. So you want to extend that osteoplasty posterior. If you're making a bar and you're going to cantilever an attachment, you want to extend it beyond that, because what you don't want is the attachment running uphill. So again, in summary, on this case, you have the ability to do anything that you want. The A and the E position, I showed you that case. If you're going to do 2 implants, the BD is a lot more favorable. A and E gives you that anterior and posterior cantilever effect, and it's going to teeter-totter on you. So the BD position is more ideal. Also, the A and the E position, sometimes because of the angulation of the mandible, you will, in the resorption pattern in the mandible, you'll get too close to the lingual plate in that A&E position. So say if you're doing a locator attachment right there, you'll be popping through the lingual where you have to bulk up the acrylic, and then your patient will be complaining of speech problems, etc., things like that. So On this case, that is for an overdenture, and I stress again, please explain to the patient all the options. Don't be just a two-plant overdenture doctor. Explain 3, 4, or 5, and you will see the patients, if you explain that to them and give them good analogies that they can remember. You know, if they come back after a 2-implant overdenture and say, you know, I really don't like this, and you go, remember the 2-legged chair? And they will remember it, especially if you give that to them in writing. So couple things. Well, let's go ahead and do the question and answers, and then we'll finish up at the very end. So Dr. Alabasi, do we have any questions and questions?
Yes, sir. We've got many. What is your opinion on mini implants for a mandibular denture?
Mini implants, that could be a whole day lecture. Mini implants in some cases work out very well. In some cases, they work out very poorly. I look at the Mish Institute has been around for 35 years now. The reason why we've been around for so long, and we're the largest institute for implant education, is we teach predictability. And can you do mini implants? Certainly. In a lot of cases, they work very well. But in a lot of cases, they don't. And we always try not to have complications or failures. And that's why we do predictable treatment. What I don't like and what I caution people on is I see a lot of complications now. In fact, I'm putting a whole new section in the next edition on the complication book on this, is flapless surgery. A lot of doctors who do mini implants do them flapless, and there's a lot of case reports in sublingual bleeds, perforation of the mandible, perforation of the cortical plates. And if you look at biomechanics, even smaller diameter implants, a 3.0 or a 3.5, have better stress distribution. So to answer your question, can it work? Yes, we've done mini implants for 30 some years. We used to do them as temporary implants back, you know, in the 90s. But I believe it's more predictable, and the prosthesis has less complications with regular size implants.
Thank you. So what is the minimum length of an implant that can be placed in the posterior mandible, posterior to the mental foramina? So yeah, that's basically it. What is the minimum length of the implant?
Okay, well, that's a little bit difficult question to answer because there's so many variables. But let's talk. Let me try to answer it this way. In the past, we always thought that shorter implants were not ideal because of the biomechanics. We wanted the longest implant possible. In the early days of Brandemark, we had 18, 20 millimeter implants. We tried to get bicortical stabilization. Because of the better coatings, the better surface areas on these implants, they're more predictable. So because of that, we don't need that long implant anymore unless we have poor bone quality. So if you have poor bone quality, you need primary stability where you need a longer implant. Where do we like to stop at is usually we're looking at our shortest implant being around 8 millimeters. If you look at a definition of a short implant, most of the literature now goes about 7 to 8 millimeters is a short implant. And ultra short is 4, 5, 6 millimeter implants. And do they work? Yes. So could you put a 5 or 6 millimeter implant length implant in if you have anterior implants that you're going to splint together? Yes. Would I want a 5 millimeter implant in poor bone quality against a 350-pound linebacker with parafunction? Probably not. So it's case specific, but to answer the question, ideally our short implants are 8 millimeters. In some cases, some systems, that would be a 7 millimeter.
Thank you. Any precautions about placing implants in site C in the midline? I'm presuming they're talking about the lingual foramen.
Yeah, so the median vascular canal, I believe they're probably saying. So the median vascular canal is a very similar canal, similar to the canalis cyanosis, that carries basically blood vessels, and it's carries the right and left sublingual artery. There are case reports that you can have extensive bleeding in that anterior mandible from it. I've seen more bleeding. I have never seen one that you can't control. Usually interosseous bleeding is easily controlled by putting the implant in, putting a burr in, putting a direction indicator in, anything that will clot it off. Now, an extraosseous bleed is where you get into the sublingual bleed. So if they're talking in the anterior mandible, and if they perforate, why you never want to perforate in the anterior mandible is there is the sublingual arteries, also the submental arteries, and that will lead to possibly a sublingual hematoma, floor of the mouth swelling, compromised airways, et cetera, et cetera. If you look at the most compromised area in the anterior mandible, the central and lateral is not the most compromised. It's the cuspid area because of the curvature of the mandible. The sublingual artery is very close to the lingual cortical plate there. So that's why you have to be very careful on not perforating in that area.
Fantastic. What is the success rate between bar overdenture versus locator overdenture? And also with 2 implants, would you recommend a locator or bar?
Okay, if you look at the studies are all over the place on what type of attachment, bar versus attachment. Historically, it was always thought a bar would be better and more predictable. And we did bars for many, many years. However, with the newer type of attachments, what is nice about the locator, what is nice about the O-ring is it allows that attachment to move. So it has a shock absorber in it. So we're seeing very positive case studies and meta-analysis studies that are very favorable for independent attachments, meaning non-bar like. If most of the studies out there, if you look at the older ones, bars do have maybe a little bit higher success rate. I would say right now it's not that significant in the mandible. In the maxilla, because of the poor quality of bone, because of the trajectory that implants need to be placed, I would probably say a bar would be better in the maxilla. Now, that doesn't mean that you have to do it on every case. Again, if it is opposing a fixed dentition, parafunction, force factor issues, yeah, a bar would be better. If it's opposing a denture, low force factors, no problem. So I believe the second part of the question was, when can you do a 2-implant overdenture? Was that the question?
It was with 2 implants, could you do a bar?
Oh, yes, you can. The only problem with a bar that you're going to do is a lot of people make clips on bars or cantilever, and you want them, 2-implant overdentures have to rotate. So what you want to do is if you do a bar, you can do like a hater clip right between the 2 implants. That's perfect. A hater clip allows it to rotate. However, you don't want to do cantilever hater clips because then it makes it a fixed prosthesis because it can't rotate in that single plane. The cantilevers would be in different planes, which basically would make that a fixed prosthesis.
All right. Another question is, would you or could you place ABCDE implants and configure an RP4? If yes, then why not an FP3?
Good question. We don't make very many RP4s anymore, to be honest with you. Most people go to an FP3, a fixed prosthesis. Some people do and there's not that many. I've had a couple patients in my career where they didn't like a fixed prosthesis because it was hard to clean. I actually had one patient that went from a fixed prosthesis to an RP4 because it was easier to clean. But I would call that an anomaly. Most patients now want fixed. If you look at how implant dentistry has evolved, the all-in-4, the immediate prostheses, we're going to almost fixed majority of cases now. So there are still cases that an RP4 would be a good case. But remember, an RP4 is a fixed prosthesis. So it will not move on you. It's just the patient can remove it. But bite-wise, force-wise, it's basically a fixed prosthesis. Another possibility is an RP4 can be a slightly less expensive than a full-blown FP3 monolithic zirconia prosthesis. So that could be another indication.
All right. If you have 5 millimeters as the minimal interocclusal distance for a zirconium restoration, is this for full arch cases or just single crowns?
It's ideally you want more than that. Okay, so I'm telling you what the literature states. What I don't like about 5 millimeters is the aesthetics of the prosthesis. Yes, you can get it to fit within that patient's vertical dimension. However, you're really going to be compromised on the aesthetics, and that's really pushing that material to the limit. I would like more, but it is for a single or a full arch, but certainly the more, the better.
Dr. Resnik, do you have any input regarding vaping as opposed to smoking?
Interesting. I did some research for the new textbook on vaping. Number one, because I didn't even understand vaping. I didn't know what it was. And I wanted to see what the studies were showing, how it relates or how it is compared to smoking. And there are a couple studies out there. So what it states is vaping is not as bad as smoking, but it still does increase the risk of soft and hard tissue complications. So there's a couple studies that I highlight in the book that do go over that. So I would say it's better than smoking, but it's not as good as no smoking or no vaping.
All right. Dr. Resnik, speaking of the book, I've got many questions asking about which book are you referring to, and also someone did ask if it's possible to do the MISH Institute course online. Would you consider doing S1 to S5 courses online using these live webinars?
Okay, so here let me go to this. Heidi is on the line, so if you do have a question, she can get right back to you. Our first course that coming back from the pandemic is going to be in September. Now, the reason why that, I'll go back online here. The reason why we are still going to be doing these live is the MISH Institute has been built on basically taking doctor skills to the next level. And we have a huge hands-on portion to this, hands-on laboratory sessions. So everything that we teach in our courses, you go and you do on a model, or soft tissue procedures on pig jaws or pig's feet, whatever. So we have a lot of hands-on that needs to be done in a clinical or in a continuum setting. Going back or looking towards the future, these webinars, we've gotten so many positive reviews on this that we will most likely start doing more webinars. I can see this as an adjunct to what we're doing right now in our regular S1 through S5 classes. One problem that for some of our doctors who are going through our courses now, You know that I get you up early. I mean, I believe at S1, our last course, we started on Saturday at 6:30 in the morning because I had so much material to get through. There is more material. Implant dentistry is getting more complex. So what I believe we're going to be doing is doing more webinars for certain subjects, but we'll still be doing the live hands-on webinars. As for the books, the book that I've mainly been referring to is the Contemporary Implant Dentistry. It's the 4th edition that was just published in February. That can be, you can get that from elsevier.com or amazon.com. It's the one that is just published. We've been getting great responses on that. The complication book that I also mentioned was published in 2017. That's basically on complications, how to prevent them, prevalence of them, how to manage them if they do occur. So that is basically about the books. Was there anything else, Dr. Alabassi?
Yes, we do have a couple.
Okay, well, here, let
Whenever-
me, because I do see some, and I just said that, I do want to thank everyone who helped out. Robert's done a great job with all the questions. Dr. Alabassi's doing an unbelievable job kind of coordinating all this. I know Heidi's been real busy with the MISH questions, and Dr. Conness has been, I see all the question and answers coming in, so I know he's been busy. So we'll do a couple more questions, but I just want to thank everyone before everyone starts going off. So why don't we do a couple more?
Sure. Regarding the mandible flexing, can you please explain what exactly is mandible flex?
Okay, so mandibular flexure means that posterior to the mental foramen, the mandible flexes towards the midline, okay, from the medial pterygoid muscle. So what happens is when the patient opens up, it flexes. So if you have a fixed, theoretically, if you have a fixed prosthesis from molar to molar, the patient will not be able to open their mouth wide enough, or if they do, a lot of times they will get pain. How did we know this actually does occur? We used to do subperiosteal implants, and we would have a ramus strut on each side, and patients would come back and they wouldn't be able to open up. So then we redesigned it so it would be open. So mandibular flexure, there is one study out there that I highlight in the book that talks about the number one reason of failure for posterior implants is mandibular flexure, and it is basically from rigidly fixating a molar to molar implant.
All right. Now, quick question to Heidi that you can answer later on. Can you email us a copy of the implant option form as a reference?
Yes, so Heidi will be emailing you tomorrow your CE credits. She'll also send you that treatment plan form that I have and all the advantages and disadvantages. Please start using it. I'll tell you a quick story. I had one of our doctors about 2 or 3 years ago went through the course, and he sat in the front row, almost never answered any question, almost never said anything. He calls me in distress one day. It's a year or two after the course. He goes, I just did 2 implants on a patient. The patient wants to sue me. They hate it, this and that. And I said, did you use my form? And he goes, yes. And I go back, show him the form, and explain that he just needs more implants and he'll be happy. And what happened was he did. He went back, and this doctor actually emailed the form to the patient. So now there's a paper trail of it, which was great. When it ended up, he called me, he put one more implant in the C position. It got rid of that teeter-totter effect. Patient was happy, ended up doing implants on the patient's wife. So here is a story from almost getting sued, which is that wouldn't happen. I mean, it could happen, but that wouldn't be successful. But going from almost getting sued to basically getting paid to do one more implant on the patient and doing the patient's wife. So Heidi will send that to all the doctors in the email.
Thank you, Dr. Resnik. One final question.
Yes.
We did get many questions regarding zygomatic implants. Would you ever consider zygomatic implants to avoid sinus augmentation?
I'll give you my position on it. Sinus augmentation is, I believe it's one of the easiest and one of the fastest procedures I do. It has the highest success rate out of anywhere I grow bone. The sinus grows bone very easily. And now we have the modified sinus graft where we do them crestally also. So there's an alternative to doing lateral walls. I can't see to bypass the sinus. The only reason I would bypass the sinus if there was a developmental or a pathologic reason that you couldn't go into that sinus. And that is so rare that it would just be very rare. So zygomatic implants, pterygoid plate implants, they in the studies out there do have good success rates, but they're very invasive and they're not shy of complications. So I think it's a lot simpler, easier lateral wall sinus grafts or crestal grafts.
Thank you very much, Dr. Resnik.
Okay.
And the rest of the questions will be answered by Dr. Resnik via email. And thank you very much.
Okay, thank you to everyone. Stay safe out there. I'm glad people are getting back to work, and hopefully we'll see you on one of the future webinars. Thank you. Everyone have a great night.